places it's morning, some places it's afternoon, and some other places it will be night. So good day for everyone. Today we are continuing our webinar. EPSA online webinar weekly has been going on for some time now with very good success. Our topic today is on abdominal wall defects, and we have three distinguished speakers with us. We have Mr. Amolia Saxena, consultant pediatric surgeon, Chelsea and Westminster Hospital, Imperial College London, and he's the editor-in-chief of the Journal of Pediatric Endoscopic Surgery. We have Professor Osama Najjar, professor and head of pediatric surgery at Ain Shams University. We have Professor Ali Shalabi, professor of pediatric surgery, Cairo University. I have my co-chair, Dr. Sharif Qaddah, who is sitting in a very nice surroundings, and he will welcome you again before we start our first speaker. Dr. Sharif.
So it's a pleasure to just join this distinguished webinar. I'm just very happy to be with the group, and today we're just attending an interesting subject or a very good topic that we have pretty good experts in this meeting who have dealt with this congenital anomalies of the abdominal wall defects. Dr. Osama Najjar, Dr. Amolia, Ali Shalabi, my dearest colleague, and I hope it would be a nice night with all the attendants. Thank you very much.
Okay, we start with Amolia. Please go ahead. The mic is yours.
Can I share my screen?
Yes, please go ahead.
I need to get the access.
All right, Tamer. Now we can
okay, Dr. Moya, you can share your screen.
Yeah.
Can you see the screen now?
Yeah, perfect.
Okay. Thank you, Sameh, for this introduction, and thank you for the Association of Pediatric Surgeons to hold this webinar and invite me for the talk on abdominal wall defects. Somehow, abdominal wall defects have lost charm in the pediatric surgical world, especially because most of the people have been focusing on other pathologies, congenital pathologies like anorectal malformations, esophageal atresia, and of course the lung anomalies. So we will go through this talk to see what are the problems that are still facing us in abdominal wall defects, and what are the problems and how we are able to find some solutions. We do not have all the solutions to these defects. So the areas which I will focus in my talk today are the prenatal aspects, both in gastroschisis and Omphaloceles, the mode of delivery, a cesarean versus vaginal mode. This is also under a lot of discussion. The surgical approach management, and in specific, I will touch upon the biomaterials, and finally on the outcomes in abdominal wall defects. And there is data which is constantly emerging, which is quite exciting to see. We start with the prenatal gastroschisis and Omphaloceles. The timing of gastroschisis is something that is of utmost importance. It is classified into two types. The first type is called prenatal gastroschisis, in which the herniation occurs early in gestation, and the extruded organs are covered by a very thick exudate. This is the motile type of gut what you get in these patients. Then you have the perinatal event, or the perinatal gastroschisis, in which the herniation is more of a recent origin, and the extruded organs are relatively normal. These are the babies who are born with very nice gut, which you can push back and close them with the primary repairs. Now, what is very important when you see the prenatal gastroschisis, the gut takes an insult, and you can see the difference in the ultrasounds of the fetal scans, that the gut gets thickened even within a week's time. So you can see scans on the left-hand side of the 36 plus 4 gestational week, and on the 36 plus 4 gestational weeks, you can see how much thickening happens at that time. So very early prenatal gastroschisis are prone to give you very mottled gut and adherent gut, which causes problems in terms of identifying atrasias and managing them surgically. Now, one very important aspect, and especially in countries where fetal counseling is done, is the bowel diameter, and especially in gastroschisis. As you can see in the second trimester, it is possible to identify a gastroschisis in a fetus. And at the third trimester, you see that there's a measurement of 10 millimeter. Now, what does bowel diameter and these dimension actually specify, and what can we predict out of these values? When you see that bowel diameter, when it's larger than 11 or 17 millimeters, these are associated with postnatal bowel complications. So when you see the diameter increasing in size, you're very much sure that there is a problem with the gut, and these children will have surgery on the gut, not the closure of the abdominal wall, but also the gut. Dilated stomach is even a bigger problem because these fetus have an increased risk of volvulus and fetal death. So both the bowel diameter and the stomach has to be studied or has to be determined so that you can give the proper information to the parents who are coming for the fetal counseling. Now, stomach dilatation and gastroschisis was measured, and affected fetus showed that the dilatation 10 to 22 weeks after the diagnosis. Now, gastric dilatation at the time of delivery is definitely associated with complications, and that is the timing of the dilatation. The interval between the detection and delivery, if it is greater than 7 days, the complication is a volvulus or death. If it is less than 7 days, it is major gastrointestinal complication. So it's very important to note the time that the stomach dilatation takes place in these fetus. Other sonographic fractures were done in a study on 158 gastroschisis fetus that were less than 24 gestational week. Interesting findings of ultrasound are further that the abdominal perimeter, if it is less than 5%, and you have an abnormal gastric bubble and an abnormal stomach location, all these findings are associated with perinatal mortality. If you have a gastric dilatation, as I mentioned before, prior to surgery, there will be a need for bowel resection. Now, you move from gastroschisis to omphaloceles, and the issue in neonates with omphaloceles is the herniation of the liver, intestine, it may be the stomach or the spleen, and the bigger problem what we have is an underdeveloped abdominal cavity to accept these organs back inside. One important fact in fetus or in newborns with omphaloceles is lung hypoplasia, or something which we call a restrictive syndrome, depending of course on the size of the omphalocele. And the abdominal defect, this is something that needs to be better understood, small size defect or large size defects. Now, when you look at the embryology of omphaloceles and the variations in the large size defects, there's an early teratogenic insult. An embryonic lateral folding, which takes place in the 6th week, fails at this time to close. And that's why you have this large organ protruding, as well as what we call a large defect. The smaller defects are more complex abnormality of the lateral folding. And what exactly happens is there is an abdominal closure even before the or the liver retraction can take place sometime. So these are complex abnormalities, and the mechanism has not been completely understood. There is a category in omphaloceles which is called the non-giant giant omphalocele, and these have the most unfavorable prognosis. The reason for this is an underdeveloped abdominal musculature, thoracolumbar scoliosis, lung hypoplasia, which is the biggest problem in these newborns, and a very small thorax, and a deformed thorax with a very shallow abdomen. The problem again in these patients is this abnormally long vessels that go up to the liver. So if any attempt is made to bring the liver down, you will have a kinking of these vessels, and you might have at the same time you have at the same time death of the newborn. So what happens is in large omphaloceles, you have then abdominothoracic mismatch. There's an increase in overall perinatal morbidity and a high mortality because you have a small thorax and you have a lung which is hypoplastic also, and you have an underdeveloped abdominal cavity. Now, one very interesting fact is that the shape of the liver in omphaloceles, which you see as an abnormal globular shape, always remains throughout the life. And it's this elongated hepatic vascular pedicle is always at the risk of kinking if you try to close these patients, and you might have immediate necrosis of the liver and death of the patient. The abnormal position of the liver and the shape of the liver was very nicely published in this report in 2001, in which the ectopia of the liver was found even in an adult who was associated with an omphalocele repair as a neonate. So what never happens in these children is that the liver returns to the normal shape and the normal position as in a human or in a person who has never had omphaloceles. So you have marked angulation, IVC in the right atrium. You have abnormal retrohepatic course of the vena cava, which is always a problem, and then a chance of a thrombosis of the vena cava due to kinking, which is tried when at the time you try to repair these defects. There has been a lot of discussion about the mode of delivery, cesarean versus vaginal, and I think we need to touch this topic while we talk about gastroschisis and omphaloceles. Now, the mode of delivery and the outcomes of infants with gastroschisis was very nicely reported in a meta-analysis of observational studies in which the Cochrane reviews as well as the Medline and the other databases were searched. What was very important that it was found that there is insufficient evidence to advocate the use of a cesarean section over vaginal delivery for infants with gastroschisis. When you look at, again, the deliveries and the mortality risks and gestation, a study in 2017 with over 2 million pregnancies identified 860 cases of gastroschisis. What was very important that there was a stillbirth rate of gastroschisis, which was approximately 4.8%, and an infant death occurred in 8.3%. What was more interesting was that the prospective risk of a stillbirth increased in the beginning of the 35th week. So that's where death starts increasing in the fetus or in the newborns, rising to 13.9 per 1,000 pregnancies at the 39th week. So the more you delay the pregnancy, they found out there were more fetal or neonatal deaths. What the conclusions were that the risk of prenatal and postnatal mortality for fetus with gastroschisis may be minimized with the delivery as early as 37 weeks. Now, this is what was done in a study published in 2016, and you can see that attempted vaginal delivery is becoming increasingly prevalent in gastroschisis. When you see between 34 to 37 weeks, almost 50% of the centers are performing attempted vaginal deliveries. Between the 37th to 39th week, that is the next 2 weeks, it's around 30%. And after 39th week, very few, it is between 15 to 18% that are performing these deliveries. So what the trend has shifted towards is now performing attempted vaginal deliveries between the 34th to the 37th week. We now move on to the surgical approach in management. And unfortunately, there are very few standards in the surgical approach. So what out here is that no single technique is applicable in all circumstances, and management should be tailored to the individual neonate. It's better to choose the best possible surgical technique for the individual patient and do not adapt any favorite technique which you have. Look at the patient, understand the pathology, and try to use the best technique that you know or you can find which can be adapted for this patient. Now, primary closure of gastroschisis definitely can be done. You have infants which are born or newborns which come out with the gut, as you see, pristine like this. You do a meconium lysis, remove all the meconium, and it's very easy and comfortable to put back the gut without any added abdominal pressure back into the abdomen through the defect. And you can close these defects with a simple stitch. So of course you will have patients like these, which I call are just perinatal gastroschisis, or the insult is just quite recent to the birth of this newborn. And of course, that goes same for omphaloceles. Primary closure of omphaloceles is possible. As you can see in this case, you can just lift the entire sac as well as the gut falls down. There is very little adhesions, and also with a simple stitch, you can manage it. Now, there are contraindications to primary closure, and these have to be understood. The poor general condition of the neonate, poor condition of the bowel, severe edema of the intestines, and there's a large disparity between the abdominal contents and abdominal size. These are reasons that you will not go in for a primary closure. Now, the surgical goals remain only two, and these are very simple: reduction of the viscera without creating an abdominal compartment, as well as careful mobilization and reduction of the liver, especially in omphaloceles, avoiding any type of rotation. Now, when you put in the intestine, the question which everyone asks is how tight is too tight? So what is generally considered good is the measurement of intragastric and intravesical pressures. They should be around less than 20 centimeters of water. There are many factors that can determine that your abdominal pressure is the right, or if any of these factors are creating a problem or unstable, then you should immediately realize that your closure is very tight and you might be heading towards an abdominal compartment syndrome. Now, the problem comes when you have these large defects. As on the left-hand side, you can see the defect is small. Everything, including the liver, has just popped out, and the spleen is outside with the intestine. There is an absolute mismatch in the gastroschisis and trying to do a primary closure in these children. And the giant omphaloceles, as you can see on this type, which is what comes more or less as a non-giant giant omphalocele, with a large stock of vessels going to the liver. So if you any attempts to try to push it down, you will kink the vessels and you will have necrosis of the liver very early. So these are the challenging cases in which you have no choice but to do a staged repair. Now, what are the approaches? And there are various approaches possible. I may not be able to list all of them, but some of the most common approaches are the silastic sheet or the silo, the Bianchi approach, the gentle touch, stage closure. Umbilical cord for temporary coverage has been used in a lot of countries because of the availability of this material directly after the newborn has been diagnosed and delivered. Biomaterials, and this is the topic which I'll be touching on a little bit more in details in my talk, as well as conservative topical applications, which is only relevant to omphaloceles. We will not do anything like this to apply any topical solutions to gastroschisis. Now we go through the different options. If you have a mismatch, one of the options would be to put a preformed silo or spring-loaded silo, as you can see over here. The silo is maintained in place for around 7 to 9 days. And after 7 to 9 days, you can attempt a direct closure if you can put the fascia together or close the facial defect. And if you cannot close the facial defect, or you have a certain amount of tension over there, I prefer to do a patch repair of the facial defect and mobilize the skin and close the skin on the top. The second option, if you don't have a preformed silo, you can use a silastic sheet, which is again sutured to the facial defect. The spring-loaded silo does not need suturing. A silastic sheet needs the suturing, again maintained for 7 to 9 days, after which the sutures which are holding the fascia start giving way, and it's followed by a direct closure if you can get all the intestine or the viscera inside, or a patch repair. Now, larger defects can be managed, as I mentioned, with patch repairs. And what we do in patch repairs is that the skin is very carefully dissected away from the fascia. And as you can see, the fascia rim is completely identified on all the sides of the defect. what you start doing is you take one of these biomaterials, and we will go a little bit more into details of the different biomaterials, and using a resorbable suture, a braided suture, you can just do fixation of these biomaterials along the edges of the fascia, close the defect, and on top of it, you can bring the skin, and that's it for some time. What this does is it avoids multiple interventions in the neonatal age because you've closed the defect and the skin on the top. And you do not need multiple anesthesias also for doing stage closures. And when this child is around, or a toddler is around 2 or 3 years of age, you can bring the fascia in together and at the same time create a belly button. Now, if you cannot close it immediately, that means you have a giant defect. And what you do is you can use a single patch, which can be again sutured with resorbable material, which is the inner patch, because this will integrate with the body and the fascia edges. And what you do is you take a second patch, which is put on the top. And generally for the second patch, you use non-resorbable monofilament material. What is very important, because this is a biomaterial and a collagen patch, you have to keep the outer patch hydrated so that the inner patch is allowed to integrate with the fascia. This is generally kept hydrated for 2 weeks, and after 2 weeks, just on the bedside, you can remove the monofilament suture, and this patch can be peeled off. And you can see that the growth of the skin on top of the first patch, integration starts. It might, depending on the size of the defect, the complete growth of the skin will take place on the defect. Now, this is what a patch would look like, and this is a large defect with 2 patches, and you can see how the skin integrates on the top of it, and it is quite well tolerated by the children. We do not have to do anything until, like I mentioned, they are 2 or 3 years of age, or just before they go to kindergarten. Now, this is one child that I operated, and of course it was published, that the defect was quite large, and you can see the edges of the fascia are pretty much not coming close together. A mid-sized defect, you will have the fascia coming at this area, but because the child was moving on the carpet, the parents came and they said the belly is scrubbing against the carpet, and I think the defect on this infant lying down is not as big as it is when you see it in real life. So what you do in these cases, an additional step might be required. So again, you open up through this scar tissue which has formed. You identify the edges of the fascia, as you can see it on both the sides. This is the left side, and same thing on the right side. And you can put a smaller patch inside. So this kind of bulge what the child has is gone, as well as you've brought the fascia on both the sides to half the distance. So when this child is around 2 or 3 years of age, or 3 or 4 years of age, you can directly put the 2 fascias together and excise the scar and do an umbilicoplasty. So these are the results, what you can do after the second stage. You can get the rectus muscle in the midline from both the sides. And very important is the umbilicoplasty, because children who go to kindergarten are very much aware that they have or do not have a belly button. So creating a nice umbilicus or a belly button is very important in these children. A quick touch on the biomaterials in abdominal wall defects. And the biomaterials, actually, whatever you get for your patient should be compared with the human fascia. And these are factors which are compared, that is the shear strength, maximum elasticity, stretch, how many 10 newtons percentage, and stretch to tear percentages. So 2 materials, biomaterials, which compared very close, and this is a very early study. At that time, there were not many biomaterials, but still these biomaterials are commercially available. That is the dura mater and the bovine pericard. Now, biomaterial is not just simply getting a patch. The integration of the biomaterial is very, very important. What you can see in the environmental study which we performed in putting biomaterials and seeing how they integrate with the body. As you can see, biomaterials which are not cross-linked, you will have integration in 12 weeks time. As you can see over here, there's a full integration of these biomaterials. When you take a cross-linked biomaterial, as you can see here, even after 12 weeks, you will not have any integration. In this, you will not have this nice coverage of scar tissue, as I showed you in the patient before. You will just have that there'll be a lot of slough on the side, and you have to keep removing it again and again, horrible integration. And this is something which you do not desire. So the only thing which is very important when you choose the biomaterial, make sure that whoever is supplying it to you, that it is not cross-linked. The advantage of cross-link is, of course, sturdiness, but the other thing is you want integration as well as sturdiness. So the approach would be to take something which is not cross-linked. Now, my personal experience is with a lot of surgical patches, and we'll just go through these. I put down the generic names over here. The first patch which we used in the 90s was the solvent-dried Dura patch. This is human Dura, which was acetone-dried. And what it was a very nice biomaterial, good integration in the fascia. It was non-cross-linked, so of course, very nice results in the end. But the problem, what happened is with the outbreak of the mad cow's disease or Creutzfeldt-Jacobs disease in 1995, this material was not sold anymore in the market. Although the literature does not show any cases of mad cow's disease being associated with patches that have been used in these patients. The next patch is the bovine pericard patch. This is also commercially available. When compared to the Dura patch, the integration is quite effective because it's not a cross-link, but I found that the Dura patches integrate much better. They took a slightly longer time than Duras to integrate. So that was the only disadvantage which I found in the bovine pericard patches. When you look at the third patch material, that is porcine small intestinal submucosa, what is very good, it is a material which is not cross-linked, so fantastic for integration. But porcine intestinal submucosa comes in as a 4-layer as well as an 8-layer. Now the problem with the 4 layers is it is very good to suture, but it does not have the mechanical sturdiness. While on the other hand, the 8-layer, it does have the mechanical sturdiness, but it's very, very thick and very difficult to suture along with the fascia. The next biomaterial is expanded PTFE. As you can see, advantages are availability of this biomaterial. Every hospital has it. But I feel that there are severe disadvantages because this material has severe adhesions, especially to the liver. It gets stuck and there is ingrowth of tissue between the liver and this material. Very difficult to peel off once it is stuck to the liver. You could have huge bleeding. It is synthetic, so you will have to remove it after some time, and that is also a disadvantage for me. The other thing is to use polyglactin meshes. And these meshes are resorbable and easily available. But the biggest problem with these meshes, which was used only in one patient, that they cause a severe inflammation. And what happens is also they break down very early. So your whole biomaterial breaks down within 2 or 3 days, and you're back to square one that you have to try some other way to repair them. Porcine dermal collagen, I have seen no advantages of this material because this material is cross-linked and it has very poor integration. So it's not the nice results which I showed you with large defects. Another very good material which is now available in the market is, and also FDA and CE approved, is the human fascia lata. Very good integration, no cross-link, and I think from the price also it's something which is much lower than most of the other biomaterials that I've used. We come to the last point, and that is the outcomes of abdominal wall defects. The question always asked is the role of preemptive LADS procedures in abdominal wall defects. And this is, that the gut is rotated in an improper way, non-rotation, malrotations. So the Pediatric Health Information System database was searched for neonates with CDH who could have these problems, gastroschisis and Omphaloceles between 2009 and 2015. And the findings were very interesting that LADS procedures performed prophylactically in patients with CDH, gastroschisis, and Omphaloceles did not reduce subsequent volvulus. So this was a level 3 evidence retrospective comparative study. Now, one thing which is also very important is that the gut immaturity should be recognized, and that's why the neonates take a lot of time to feed. there is in fact a lot of mortality in these neonates in centers that cannot offer central lines and keep their nutrition running for as much as 72 days as a mean, which has been observed worldwide. So what you see this is a rodent model study, that in gastroschisis, you have increased intestinal weight and thickness, which we all know. But what is very important, you have an abnormal myenteric plexus, which is maturation over here. So it's not as mature as the normal gut plexus. The interstitial cells of Cajal are diminished in gastroschisis, and GFAP expression of the glial cells has markedly increased in these rodents. When you look at simple and complex gastroschisis, also you can see that in simple gastroschisis, the number of surgical interventions are much lesser than in those mottled gastroschisis children that are born. And this is a significant difference. It's the same thing with the median time to full feeds, could be as low as 33 days, and 87 days in complex gastroschisis, which is also significant. And the median hospital stay is also significant between simple and complex gastroschisis. We did a systematic review, which was published in 2018, with only regarding the mortality in giant omphaloceles. And the most important factor that stuck out in this study was the respiratory insufficiency. And if you remember in the very beginning, I mentioned to you about lung hypoplasia, was the major factor contributing to death in giant omphaloceles. Of course, important, that was the second thing was major associated anomalies. Sepsis plays a very important role. Cardiac anomalies, these were the main front runners for mortality in giant omphaloceles. Now, ECMO and its outcomes in gastroschisis and omphaloceles has also been studied, and it was pointed out that infants with gastroschisis requiring ECMO support have significantly better survival than omphaloceles. What is also important, that respiratory failure is significantly associated with sepsis, as we found out in the meta-analysis and the systematic review, which we published in 2018. The majority of omphalocele infants die despite ECMO, and respiratory failure is associated with pulmonary hypertension and congenital diaphragmatic hernia. This was again a level 3 evidence in this study of a registry database. Now, cryptorchidism or undescended testicles is another issue in gastroschisis patients, and a very nice study with 62 males with gastroschisis was investigated with regards to undescended testicles. They found that in 38.7%, in 24 of the 24 patients and affecting 31 testicles, they did not descend at the time of birth. At the follow-up, which is very important, that 54.8% of the testes relocated without any intervention. Orchiopexy was performed in 38% of these. Only 3 loss of complete testicles were found. Another interesting fact was, although these children had gastroschisis, laparoscopy was safely performed in 5 infants for orchidopexy, so locating the testicle and then finally performing the procedures after that. There's a high rate of spontaneous migration in the first year of life, so there's no need to rush for an early intervention in these patients. And greater than 90% of the testicles were viable at the time of follow-up, according to the study. Now, like I told you in the very beginning, gastroschisis and omphaloceles have lost complete fashion among all these big congenital malformations. But you have to note one thing, in a study published in 2016, that the length of stay in the gastroschisis patient on the average is much higher than any of the other anomalies that you have, be it esophageal atresia or CDH or even anorectal malformations. Exomphalus on the other side, or omphaloceles on the other side, the stay has been found to be much less. And when I told you in the beginning that it is losing fashion, I do not think, because this is still one of the most expensive congenital anomaly. When you compare all the congenital anomalies, the gastroschisis is the most expensive, which comes close to 25,000 pounds, according to the study, when you compare to CDH or even esophageal atresia or meningomyelocele. Omphaloceles, of course, is the second more expensive one after meningomyelocele. So centers in which these babies do survive, the cost of maintaining their survival and to make sure that they leave the hospital is as high as 25,000, and it's the highest still among all the other congenital anomalies. The risk of long-term morbidity, and it's also important that these are normal outcomes in pathology. Normal outcomes in the first year to the 5th year is around 80%. Neurological psychomotor development, you can see, is normal in around 82% after 5 years. Audiology is, of course, this is not valid, but 76%. Vision, around close to 90%. Language, 65%. Rehospitalization, as you can see, is higher in the first year, goes down to 0.3% in the 3rd year, and after the 5th year, they have very little rehospitalization. But surgical reinterventions in the first year are 9%, and in the 5th year can be as high as 12%. So I'll come to the end of my talk and summarize that successful outcomes in abdominal wall defects is multifactorial. An unbiased technique algorithm is important for surgical repair. Proper selection of biomaterials is necessary if patch repair is required. Giant omphaloceles, even today, present challenges, and stage repair is preferred for these neonates. The long-term follow-up is necessary for possible associated comorbidities, and favorable outcomes are possible if the complexity of these defects are better understood. I thank you very much for your attention.
Thank you very much, Amolia. This is, as you said at the beginning, this lost popularity for some time, but you succeeded to revive our interest with a very nice updated coverage of this subject. So thank you very much for this. Dr. Sharif, would you like to introduce Dr. Osama? We have a very good feedback from the audience on the chat area, and we have a lot of questions for you. We'll keep the questions after we finish all the 3 talks. Now, I ask you to stop sharing, Amolia, please. And we will move on to our next distinguished speaker, Professor Osama Nagar, Professor and Head of Pediatric Surgery Department, Ain Shams University. Professor Osama.
Assalamu alaikum. Good evening, everybody. It's my pleasure to be one of the speakers of today's topic. My screen is apparently there?
Yes, nice.
Okay. Actually, the topic of today is the brown belly syndrome. And actually, when Dr. Shahata asked me to talk about this subject, I found myself in a labyrinth. And I hope that after the end of these talks, I will find a way to go away from this labyrinth. Actually, when you look at the brown belly syndrome, if you like to classify it, is it more toward the genitourinary problems or the abdominal wall defect? So you will actually find that is a mixing area or an area of mixing between the abdominal wall defects, streptocardism or uncentesis, and abdominal wall defects. In fact, the first who had discovered or who had described this anomaly was Fearless in the 19th century. And he called it the brown belly syndrome because of the appearance of the anterior abdominal wall wrinkles and outwarding of the abdominal contents from the abdomen of the patients of this problem. But actually, many physicians and surgeons find the brown belly syndrome as a definition or as a title for these patients is they found it as trivializing and offensive in a sense. And so a lot of people try to change this name, brown belly syndromes, and so to other names like the triad, the like the triad, the mesodermal dysplasia, or the Eagle-Barrett syndromes. All these names are synonyms of the Brown belly syndromes. But actually, in the next, in my talks, I will refer to the problem as Brown belly syndromes because this is the most usual term that we are accustomed for this problem. As all you know, that the Brown belly syndromes is characterized by the presence of three anomalies, three organ system anomalies. The first is anterior abdominal wall hypoplasia or aplasia. Number two is dilatation of the genitourinary system. And number three is bilateral undescent tests. Actually, this is considered nowadays as a group of patients out of the whole spectrum of Brown belly syndrome. And this is designated as what's called isolated Brown because actually there are other two groups that people are trying now to distinguish between, which are the Brown belly syndrome and associated with some other syndromes, other well-known syndromes, or the Brown belly syndromes plus, where there is an extra genitourinary problems associated with the Brown belly syndrome triads, like cardiac, pulmonary, and musculoskeletal problems. I think that all of you are aware of the appearance of the anterior abdominal wall wrinkles of the patients who are the victims of Brown belly syndrome, like this one. And these pictures shows the second of the triad of the Brown belly syndromes, where we have a dilatation of the bladder. Bladder is dilated, distended, ureters are dilated bilaterally, as well as there is a variable degree of ectasia of the renal pelvis in these patients. This represents the second element of the triad. And as well, these pictures from a laparoscopic view showing the intra-abdominal testis that is always present in the isolated forms of Brown belly syndromes. Actually, what causes Brown belly syndromes? There is two theories that are prevailing that try to explain the problems of and the system defects that occurs in the Brown belly syndrome. The first is the bladder outlet obstruction, where there is an early obstructions in the lower urinary tracts that will lead to oligohydramnios. These oligohydramnios will lead to hypoplasia of the lungs, and as well as the obstruction will lead to dysplasia of the kidneys, as well as dilatations of the bladders and the ureters and the renal pelvis. This theory, which is mechanical in origins, had now been replaced by another theory where the Brown belly syndrome is considered as a primary embryonic mesodermal arrest that will lead to dilatation without obstruction. Although this theory explains almost 85% of the cases with Brown belly syndromes, where yes, there is dilatation without obstructions, but still in 15% of patients with Brown belly syndromes, there is an actual anatomic obstruction. And this is very important group of patients that we should take care of, because we should not take into consideration, or we should not consider the Brown belly syndrome as just a stasis without obstructions in all the cases. In 15% of the Brown belly syndrome cases, there is an anatomical obstruction that should be addressed. Actually, if we look at statistics about this disease, we find that we are facing a very alarming statistics. The incidence is about 4 to 100,000 cases per year. That occurs in the as had been estimated in North America. If we take these estimates from the North America to our country, so we are faced with about 60 cases of Brown belly or 80 cases of Brown belly syndromes, representing the whole spectrum of Brown belly syndromes. But actually, the actual incidence of this condition is not well known, because now with the advent of the antenatal diagnosis of bilateral hydronephrosis, a lot of pregnancy terminations, which we don't know their numbers, is advocated and occurring, although it is not so much in our country. But pregnancy terminations can account for a percentage of cases of Brown belly syndromes that we are not counting in our statistics. We have about 20% of these cases will present as a stillbirth. And by 2 years of age, about another 30% will die. So about 50% of the patients who are born alive, who are born with brown belly syndromes will be dead by the 2 years of age. And as well as the most important survival determinant factor in these cases is kidney failures or end-stage kidney disease. And almost 70% can reach such a stage if not treated well or if left without any treatment, as we see in our talk. And the brown belly syndrome cohort of patients can account for about 15% of about 15% of patients with brown belly syndrome can receive renal transplantations at a time in their lifespan. In fact, recently, there had been an important efforts, especially from Texas, Professor Linda Baker laboratory, where they achieved the success to identify a responsible gene for the occurrence of the brown belly syndrome, where they called it filamin A gene and protein. This is a paper in 2020 where the gene that is responsible for the occurrence of the brown belly syndrome in a subset of patients with brown belly had been identified, and they call it the filamin A gene. And this gene is responsible for the control of a protein, a cross-linking protein, that they think that it is the cause for the problems and the phenotypic types or phenotypic types of brown belly syndrome that we see in our clinical practice. What about the antenatal diagnosis and management of the brown belly syndrome? In fact, the differential diagnosis of megacystis in the fetus is one of the most difficult topics and most difficult issues, where how can we differentiate between the mechanically obstructing lesion like the posterior cell valve and the non-obstructing dilated systems like the brown belly syndromes. It had been proved to be a very difficult and very denoting job, but this paper in 2018 found that insertion of the bicycloamniotic shunt, which is one of the ways to deal with the this problem or with this problem or these fetuses, to make a drainage of the urinary system, and this can help to more normal development of the kidneys, alleviates the pressure inside these systems, as well as it resumes the volume of the hydramnios, which is very important for the development of the lungs in these patients. Although we are we are dealing with non-obstructive system in the brown belly syndromes, but this group of researchers had found that there is subset of patients who can benefit from putting the bicycloamniotic shunts, and they cannot explain exactly for what reason is this, but they assume that this may be because we are talking about 15% of patients with brown belly syndrome where there is an actual anatomic obstruction, so they can benefit from this approach. If we look at to understand actually how are we going to deal with cases of brown belly syndromes when we are facing them. So I went in the last 50 years in the literatures, and I tried to revise the ways of treating these patients over the last 50 years. And actually, I found that we have two schools of thoughts that govern our way or our attitude towards the brown belly syndrome patients. The first is what's called open comprehensive total reconstruction, where everything should be corrected when the patient is presented. And the other approach, the other school, which was wait and see tailored treatment, where we adopt a conservative treatment for these patients, and then as the need develops, for example, if there is a stasis, we drain if there is a stasis or recurrent urinary tract infections, so we can interfere by doing a sort of drainage, either with a costomist, by elastomies, and even any other type of surgery. It will be dictated by the type of patients and the way he is presented for us. Before I make a details about the surgical approaches and to compare between the two schools, here as well, another important advancement in the understanding of the Prone belly syndromes, where it had been shown that the Prone belly syndrome group of patients showing a lot of phenotypic diversities and complexities. As you see here, these are two patients with Prone belly syndromes, but the appearance of the anterior abdominal wall is not the same. So always we are talking, and this fetus, still firstborn fetus with a dilated megacystis. And actually, this had been addressed in a recent papers by the same group in Texas as well, where they identify and propose what's called the phenotypic severity scoring system, where they categorize Prone belly syndromes into severity categories, and accordingly, they can get a lot of benefits in comparing results between departments or between different researchers, as well as they can help in identifying the correlations between genetic materials or a genetic basis for the disease and a specific phenotypic types. And I think that's by adopting this type or this scoring severity system, which is called ROPACE severity scoring systems. This had been validated in about 50 cases of Prone belly syndromes in this paper. And I think by implementing and adopting the details, although as you see, it's very complex way of categorizing these cases of Prone belly syndromes. But by adopting this severity score from 0 to 31, I think that we can subdivide Prone belly syndromes into groups, and according to the severity of the conditions, we can have some consensus about how to treat these patients and how to follow up them, because actually, because of the severe heterogeneity in the cases of Prone belly syndrome that are found in a sporadic case series and case reports in the literatures, there is no way to reach a consensus about how to deal with such patients. I mean, maybe every case of Prone belly syndrome is an individualized patient that needs an individualized treatment. I think actually I didn't use the ROPACE scoring system looking at my patients with Prone belly syndromes, but there is a what's called John Woodard categorization scheme or score that's help us as well to divide the cases of Prone belly syndromes into 3 categories: category 1, category 2, and category 3. And as you see, we can translate these into severe cases, category 1, moderate cases, category 2, and mild forms of category 3. And I will refer again to this scoring system or categorization systems in my talks when I talk about how I look at the management of cases of Prone belly syndrome personally. What about the comprehensive total reconstruction? The rationale behind this approach is that the reflux that's occur in more than 75% of cases, reflux, I mean the ureteric reflux, occurs, will not resolve spontaneously. The bladder capacity will not decrease, but it will increase with time. Abdominal wall infrequently improve. It can show some variations with time, but it will infrequently improve. The testes will not spontaneously descend. And here we have to say that because of the undescended testis or bilateral undescended testis in Prone belly syndrome is said to be due to mechanical factors. So without the bringing them with surgery, they will never proceed to, they will never go and descend spontaneously. And as well, there is always a high risk of urinary tract infections where this will interfere with the available renal tissues. Recurrent attacks of urinary tract infections will lead to deterioration of the renal functions, and the end result with end-stage kidney disease or renal failure in this case. So prevention of urinary tract infections by every means is a very important and paramount role in managing these cases. He pioneered in the 70s of the total neonatal comprehensive reconstruction approach was again John Woodard in North America. And actually, I think that Mr. Woodard's attitude toward this was somewhat aggressive, because actually he described, or he advocates reconstruction, whole reconstruction in the neonatal period. In the first 6 months of life, he advocates the reconstructions of whole things. That means remodeling and reconstruction of the genitourinary system. That involves tailoring resection of the distal ureters and reimplantations, a partial cystectomy, and as well abdominoplasty and bilateral orchiopexy. The very interesting thing here is that Mr. Woodard results as regards the orchiopexy is very successful and very excellent. And he claimed that because of the short distance in the neonates below 6 months of age, you can be able to bring the two testes almost always every time without resection of the testicular vessels. And this is very important points that we will come again when we talk about the testes and undescended, the testes and the undescended in Brown belly syndromes, where the resection of the testicular vessels is somewhat risky, especially in this group of patients. So Woodard's attitude, I think, was in the 70s very aggressive one, and supporters for the this approach for Brown Bailey syndromes, which is the comprehensive total reconstruction, came as well from another series from North America in 1989 by Judson Randolph, where as well by doing the total reconstructions. But actually, they did the reconstructions here, or the total interference, at an older age rather than in the neonatal periods. And their conclusion was that although abdominoplasty is of value, orchiopexy is highly successful, but they did not determine the how much of these patients' renal function had been saved or stabilized, as well as they found that even there is some deterioration in the function of the kidney functions in some of these patients. So they tried to adopt a rather selective approach rather than a complete comprehensive approach of total reconstructions. They tried to adopt a rather more selective approach, especially for the genitourinary system, but they agreed as well with early orchiopexy bilaterally and as well with the abdominoplasty early in the treatment of these patients. Another group of researchers, now not from North America, but from Brazil. And actually, I found that from Brazil, there are two very important studies in the literatures that they are adopting the total comprehensive approach for reconstructions of Brown belly syndrome. This from the famous surgeon Sami Arab in Sao Paulo in Brazil. And they as well reported their experience, and they found that here they addressed the problem or the outcome of the stabilization of the renal functions, and they claim that there is almost more than 90% stabilizations of the kidney functions had been achieved in this group of patients, although as well these operations are very lengthy. The average length of the operations is about 8 hours. And although they are not recommending doing this in the neonatal periods, they are doing it at a later age. But as well, they are claiming that doing the whole thing in one shot or in one operations makes very good results And here they address the important outcome, which is the stabilizations and preventions of deterioration of the renal function, which is very important, I think, which is very important outcome and very important goal that we have to strive for. And in 2015, we have another very important cohort of patients as well. Also, they are from Brazil. Here in this center in Brazil, we have two papers actually that increase our understandings of the Prone belly syndrome. It is one of the most important and most extensive experiences, as well as extensive experiences in Prone belly syndromes. That's as well they are advocating the whole corrections of the Prone belly defects in one shot. What are the advantages that this study had shown us? That they showed that there is a 90% stabilization of the upper tracts in their cohorts. In the lower tracts, they have 81% the achieved continent and volational voiding in 81% of cases. And in 90% of their cases of abdominoplasty, they had improved function and appearance. And for Orchiopexy, they reached up to 85% success rates. And they did circumcision for this patient as part of this approach. And they attained very less incidence of UTIs. It decreased from 89% to 39%. I think these are very impressive results if we look at the this side of the coin. But always there is a bad face for the coins. The overall complications in this series was 40%. And this ranged from complications due to obstructions of the reimplanted ureters, recurrence of reflux, problems with the cryptorchidism atrophy or ascent of the testis, bladder failure, and that needs the interventions by CIC or by doing colostomy or appendiceo with a colostomy, Mitrofanoff techniques. And still, there is some cases where there is a persistence of the abdominal flaccidities, and as well because this is a very extensive operations, we have some incidents of acute abdomen due to adhesive intestinal obstructions. If we make an analysis of these results, actually, we found that, or I found that most of the causes of failures and most of the causes of the reoperations in these 40% is dealing with the reimplantation of the ureters. And as you know, in the Prone belly syndromes, the upper part and the lower part of the ureters are different. The upper part almost is normal and it shows peristalsis, and the lower part is ectatic and dilated and show aperistalsis. And so those who are dealing with or correcting this problem in the ureters, they tend to resect the lower ends and reimplant the upper end of the ureters in the bladders. And actually, resection of the bladder of the lower end of the ureter is feared with this disturbance of each blood supply. And so this may explain the high incidence of obstructions in these reimplanted ureters. And so we can adopt another technique rather than the resection of the lower end of the ureters, but reimplanting these ureters by folding the dilated ureters, the dilated lower ends. And these techniques and its modifications, which is known as Kalsniski techniques, can help to avoid the problem of ischemia that can result by resecting this lower end of the ureter. And in fact, here there is an important concept that I want to highlight with you and let you think about. Because one of the factors, one of the reasons why our colleagues in the Latin America or in Brazil, they are recommending the comprehensive total reconstruction techniques for these patients is because of some social factors. They say that Brazil is a very big country, and actually the patient to travel to the centers where Prone belly syndrome is treated may not be easy, as well as long-term surveillance and conservative treatment and follow-up of these patients because of difficulties in access to health service may not be possible. And so they think that in addition to the good results that they had shown in their cohort of patients that I mentioned before, they think that doing this for these social reasons can be an indication for adopting these comprehensive total reconstruction technique. These points need us to think about, because actually in our countries, still we have a lot of problems for the access for health service, as well as the, although the distance in Egypt is not like that in Brazil, but still we have problems with these conditions. And so we have to consider, can we adopt this technique or not? The other school of thinking is had been presented in these papers, which is a contemporary cohort of Prone belly syndrome patients who had been treated in Emory, Atlanta, in North America as well. And in this cohort of patients, they advocate wait and see and tailor the treatment accordingly. And in fact, they are still showing in this study that there is a lot of redo surgeries, as well as a very long-term results, a long-term journey for follow-up of these patients. And maybe the results is not as good as we think. And so their recommendations is that you need a very long-term follow-up of these patients and very good health service that can provide the treatment in the proper time for these patients. This slide shows the degree of the urinary tract problems and how to deal with renal dysplasia, atelectasis, ureter dilatations. I think I covered in the previous talks. And these are some of other surgical procedures that may be needed in these patients with Prone belly syndromes, like the vasectomies, partial cystoplasties, internal ureterotomies, abdominoplasties, and Orchiopexy, laparoscopic or open, that we are going to talk now very, very soon.
3 minutes, Dr. Osama, please.
Okay. This slide as well shows differences in anteroposterior and lateral view between the posterior urethra in posterior valve and in cases of Prone belly syndrome. In the middle, there is the Prone belly syndrome, and you have to note that we have a patent urachus, a dilated bladders, we have a dilated posterior urethra, an open bladder neck, and a hypoplastic prostate and abnormal seminal vesicles. These are very important anatomical problems, or anatomical features that we have to look for when we look at the issues of fertility and sexual functions in these patients. This is, as you see, the ballooning megaliurethra in patients with Prone belly syndromes. As you know, we have either scaphoid or fusiform. Actually, the fusiform megaliurethra, where there is an affection of the corpus cavernosum, is the most serious, because this may affect the sexual performance of these patients. Usually, patients with Prone belly syndrome without megaliurethra, they can do well as males. They have no problems in their sexual functions in the future. But patients with megaliurethra may be in need for corrections, especially the scaphoid type, or the either the scaphoid type or the fusiform type. And this as well, one of the surgeries that can be done for patients with Prone belly syndrome is ureteroplasties, and as well it has certain specifications. If you look at testis in Prone belly syndrome, because it's a very important subject, we have a bilateral intra-abdominal testis, but the histology is comparable to other intra-abdominal testes. So there is no abnormal histology for these testes in as compared to other intra-abdominal testes. And so the need for Orchiopexy, putting these testes in the scrotum, is important. The goals of treatment as well is to maintain fertility, although there is a lot of paternity incidence for patients with Prone belly syndromes, because it is not only the histology or the productions of sperm that is defective in these patients, but as well the retrograde ejaculations, the absence of the prostate and the seminal vesicles. All these can contribute, can be a contributing factors for fertility issues in these patients. But the most important things is that these testes as well, they have no histological problems, but they have macroscopic peculiarities. I mean by this, that's the instance of small testes, the instance of structural abnormalities of the testes and epididymis is very common in this cohort of patients, as well as a very important entity is the weird vasculatures for these testes. Actually, all the vascular systems in the Brown Belly syndromes can be weird, can be abnormal. And so this is very important, especially if we are obliged to do a two-stage surgery, Fowler-Stevens approach. Sectioning of the testicular vessels in these patients may not be a good adjunct or may not lead to a good outcomes because of the problems associated with the macroscopic anatomy of these testes. This is an example of a laparoscopic appearance of a normal, not normal, but it's an abdominal testis with normal structures. This is another example of laparoscopic appearance of testis with separated epididymis from the testis and a thinned out testicular vessels. Then we talk about what is the preferred approach for patients with impalpable undescended testis in Brown Belly syndrome. Is it open orchidopexy or laparoscopic orchidopexy? This is an important paper, and one of the few papers actually, and I'm happy that this paper is written by Professor Saxena, who is my colleague in the talk today, who had described the peculiarities of using laparoscopy in dealing with cases of Brown Belly syndromes. And if you read the papers, you will find that he had concern about the way of introducing the strokers, fixation of the instrument, the length of the instruments, and a lot of, although the patients had a redundant and lax abdominal wall, but because of the distended and dilated genitourinary systems, the working space is not as suitable as it is. And in these papers, he had been able to do a bilateral sectioning, first stage Fowler-Stevens in 11 cases of Brown Belly syndrome. When we come to the sexual function and fertility, as I said, sexual function is normal in most of these cases, except if you have megaluretra, and if it is of the fusiform type, that affects the turbora cavernosa, so they can work as a normal male. According to the fertility and gonads, the gonads is not abnormal histologically, but there is other factors that can contribute to the infertility in these patients, like, as I said, the abnormalities in the seminal vesicles, the prostates, the retrograde ejaculation. All these factors can contribute to the infertility. But still, orchidopexy is one of the most important surgical interventions. All doctors agree that by 1 year, all the patients with Brown Belly syndrome should have their testes in the scrotum. And this is because even if they have problems in inseminations, but you can, in the era of advancements in artificial inseminations, you can have a more easy access for these testes, so you can harvest the spermatozoa through biopsies or open techniques, and then these patients can have paternity through artificial insemination. This is a paper that documented that the sexual functions and the potential for fertility in 2020, and these are as well from our Brazilian colleagues, Lopez and Ital, and they found that those patients, they have the potential for paternity, and so we should not deny them these potentials by trying to put their testes in its scrotal position. Abdominal wall hypoplasia and aplasia. Actually, the abdominal wall problems in Brown Belly syndrome is not only cosmetics, but as well it has a functional sequelae. They lead to pulmonary problems, gastrointestinal problems like constipations, as well as it leads to spinal deformities, and that can lead to scoliosis and difficulties in motor function of these patients. What are the techniques of abdominoplasty in Brown Belly syndromes? We have to look at this. We have two groups of techniques. Actually, the first is what we can call traditional ways of dealing with the problem of the laxity of the anterior abdominal wall. And this can span between Randolph, Ehrlich, Monfort, Smith. All these are names of people who had pioneered the ways of application. The thing here, or the important principle here, is that they applicate these fascial, musculofascial structures, try to strengthen them, and this can, in their views, can help to improve the cosmesis. Yes, they can help to improve cosmesis, but actually, because there is no objective ways to assess the sequelae or the functions or outcome of these abdominoplasties, in fact, these abdominoplasties does not increase the motor proficiency of these patients with Brown belly syndromes too much. So this casts a doubt about when and how are we in need to do these traditional ways of abdominoplasties as prescribed by these authors. And that's why a need for a more objective ways to assess patients pre-operatively and post-operatively to be able to understand the quantitative benefits that these patients take from the different techniques of abdominoplasties should be available. And this as well had been provided by our colleagues in the physiotherapy, where they're giving an objective ways to assess the motor proficiency of these patients. So we can say in an objective way, how does the functions improve in these patients? And because the literature found that abdominoplasty techniques, as traditional as I described them just now, cannot give the best results. These are some pictures of the techniques. Monfort techniques is doing plication in the vertical directions. This is transverse versions of Monfort technique in the transverse way. This is abdominoplasty in Brown belly syndrome by Smith et al. In 2014. And actually, they try to solve a part of the problem of the abdominoplasty and its lack of good results as regards the functions for these patients, and they adopted laparoscopy. And by adopting laparoscopic techniques, they try to categorize and identify where is the most areas of weakness that is present in the anterior abdominal wall, and you have to go and target these areas. So by doing this, they can modify the techniques of traditional abdominoplasty that we described by attacking and by directing their efforts to their weakest areas. And so by doing this, they claim that they may have a better outcome. But because of the lack of this, the efficiency of the cases of traditional abdominoplasty, there is now an increase in what we call a dynamic abdominoplasty. There is an increased tendency of transferring skeletal muscles from the thigh and putting it in the abdomen, and this is considered as a sort of muscular flaps, and they are calling it a dynamic abdominoplasty, and they are claiming that there is a hope and there is a value for doing this skeletal muscles transfer with low morbidities and high rates of functional outcome in these patients. So the dynamic abdominoplasty may be the next era or the next step or the next directions in the abdominoplasty armamentarium in cases of Brown belly syndrome. Now, after
yes.
I give, this is the two last slide. This is my personal view about how to deal with management of Brown belly syndrome. First, it is a multidisciplinary approach. Second, I categorize my patients into Woodard category 1, where I adopt conservative treatment if they survive, because most of these patients may not survive. If they are Woodard category 2, and if you remember, this is a moderate severity. So 1/3 will die from renal failure. 2/3 can benefit from selective, where we have to select the way of dealing our remodelings and reconstructions of the urinary tracts. Comprehensive surgery, where by age of 1 we do orchidopexy in an open techniques with abdominoplasty, and a lateral diaphyseculum excision if we have a persistent urachus that works as a diaphyseculum that accumulate urine and be a source of recurrent infection. In order category 3, where it is a mild form of Prune belly syndromes, they are more stable, less severe renal functions. We are going to do Orchiopexy, and then abdominoplasty will not be considered in every patient, but we have first to objectively assess the need for this abdominoplasty and determine the time for the abdominoplasty according to this objective assessment. Then the urological surgery as required, divergence, tailoring, reimplantation as required, especially in these mild or category 3 zone ordered classifications. What are the future directions? More validations and implementation of the ROBASE. I think that this scoring system should be considered by surgeons because it can represent a step forward in understanding and managing cases of Prune belly syndrome. Genetic investigations for targeted therapy, and I think as I had shown in my talk that this started already. Comparative studies should be done between the comprehensive treatment and wait and see tailored treatment. And as you know, this is a rare disease, and this may not be as easy as we imagined. But without the comparative studies, we cannot say which school of thinking is better: comprehensive reconstructions or tailored treatment. Dynamic abdominoplasty rather than traditional abdominoplasty should be the way, but determining the indications and timing is very important. Antenatal diagnosis and management may be of value in improving results with these cases. I hope that I find some way or a way outside of the labyrinth of the Prune belly syndrome. Thank you very much for your attention, and thank you, Dr. Sami Shahata, for choosing this topic for me. Thank you very much.
Thank you very much, Professor Osama, for a very comprehensive coverage of a difficult subject with a lot of updates. Now I ask my co-chair, Professor Sharif Khaddah, to introduce the next speaker.
Thank you very much. Our next speaker is Dr. Ali Shalabi. He's the lecturer of pediatric surgery in Cairo University, and surely you can just rank him as a professor, as you said, Sameh, with his work and activity, but he's younger than us, definitely in age, but active, and he's a rising star in this part of work in pediatric surgery. Dr. Ali.
Excellent. Thank you all. Sorry, I was muted by the admin. Do I have sharing? I need some screen sharing.
Okay, you can
Excellent.
go ahead.
Yes, perfect. Yes, it's working now. So thank you all for attending and for inviting me. It's a real pleasure to be here. Thankfully, my presentation is short, so we'll be done quite quickly. I really am honored to present our experience with gastroschisis at our unit, which is a tertiary care center that is really unique in the sense that it has a dedicated intensive care unit for neonatal surgical cases. And I'd like to thank my colleagues who have really contributed to this current study, Dr. Mohammed Alem and Dr. Ala Obaida. Dr. Sharif is obviously here, and Dr. Khalid, the director of the unit, is joining us as well. So we created a database at our unit to cover really a great deal of the variables that affect gastroschisis, and we're slowly looking back on these variables to try and extract some data to improve our outcomes. The 5 points here are what is covered in the database, but those that are highlighted in yellow are what I'm going to talk about today. And our main outcome really is obviously the survival, because that is an issue in our part of the world. The results of our database today show that we have a gastroschisis of 6.3% admission in our unit, in the whole hospital. What I'm talking about today will cover a 27-month duration, which you'll see is in 2 distinct time periods with a total of 53 cases. The first time period from 2017 to 2018, we have published in the Journal of Pediatric Surgery earlier this year, and covers quite a lot of detail on the risk factors of gastroschisis. You'll find that in the 2 time periods, there hasn't been a huge difference in the number of cases, so the incidence is pretty much the same, although the ratio between male and female seems to be the opposite in the 2 time settings. The outcome, unfortunately, is not great. The mortality remains really high, over 60%. And that puts us quite in the top range in the African countries between Nigeria and Malawi. And this obviously is a stark contrast to the mortality in high-income countries, where the mortality is anywhere from 0 to 10%. And that 10% is probably also related to complex gastroschisis. There is a silver lining. So the first study period that we did in 2017 had quite a high mortality. So only 1 case survived out of 8 in the first part of our study period. And then when we realized that there was no standardization of the resuscitation or the care, we enforced a very rigid protocol for resuscitating these babies and a really strict protocol and criteria to take them to theater, so they were not rushed to theater. And we saw a huge increase in survival. Now, of course, this has to be taken very lightly. This is an association. It is not a causality. We can't say that this change in survival is caused by the application of our protocol, but it certainly did help. And it also helped in terms of training our junior doctors, junior surgeons, and junior trainees in managing gastroschisis. Because if we go back to the mortality, obviously it hasn't changed. And as we all know, it's multifactorial, and sepsis is a huge contributor to mortality in this particular condition. And we'll see some more factors as we go along. So again, in 2017, we used a validated questionnaire to look at the socioeconomic standard of the families. And as what is described in the literature, the same applies to Egypt. Our families come from the very low or low socioeconomic standard. It's not here in the presentation, but also the maternal age was quite young. Unsurprisingly, the cases that have a normal birth weight and a low birth weight have slightly better survival. None of the cases that had very low birth weight survived, and the best survival was with those in the normal birth weight range. We do serve almost the whole of Egypt. Obviously, the Cairo and Giza is our immediate vicinity, and that has the highest number of cases. And we do get cases even further than 200 kilometers away. And we've looked extensively at that. You would expect maybe that the survival rate is higher in Cairo, but it is not. And again, this is due to multifactorial causes. It's not just the distance and the time to transfer. But this slide, we feel, really makes a case for working on referral pathways and possibly improved resuscitation at the point of care if some of these regional centers are unable to further manage gastroschisis. A lot of the cases that come to our unit are not even wrapped in cling film. They're just, the bowel is completely exposed or wrapped in wet gauze, which is incorrect, or left exposed and covered with just normal sheets. This is actually one of the interesting outcomes of what we published earlier this year. Added to it the extra 27 cases from 2019. We tried to define what a delayed transfer meant. And it would appear that anything beyond 8 hours is associated with quite a high mortality. Now, we haven't run the statistics on this full number yet because we still have more cases that we are analyzing. But when we analyzed the first cohort from 2017 to 2018, there was no statistical difference between those who were transferred in less than 7 hours or to those who were not. So those who came in much longer. But you can see clearly that the blue dots, which represent the survival, are more clustered towards the left-hand side, so towards less than 7 hours than those who took longer to transfer. We also measured the time it took to go to theater, and we looked at the association with that and the survival. And those patients who were resuscitated adequately, and I stress on the word adequately, and quickly, and were in theater in less than 12 hours survived the most. And unsurprisingly, those who took longer to resuscitate did not make it. And that could be a reflection of just how sick they were on arrival and how long it took to resuscitate or to try to resuscitate them. When we look at the different surgical options that we had on our unit, those on the right-hand side in orange, the complex gastroschisis, unfortunately, none of them survived despite the different types of closure. On the left-hand side, the simple gastroschisis, the best survival was for cases who had primary closure, followed by those who had a stage silo at 28, almost 30%. Skin closure had the worst survival. Most of them actually died, and we do actively discourage this because it is probably an indication that this child is going to go into compartment syndrome, and if not picked up very early, it is very rapidly fatal. So in conclusion, the mortality in our center and very probably in the country is very high. We found it essential to use a standardized management protocol, and it's really the resuscitation at birth and resuscitation on admission is really what will save this child's life. We feel that referral pathways will really decrease the transfer time and improve survival. We have suggested that a transfer time of less than 8 hours will increase survival, and getting the child to theater in less than 12 hours is also associated with a positive outcome. Thank you very much for your attention.
Thank you very much, Ali. Actually, it's very impressive study that leads to a lot of conclusions about how to reduce the very high mortality in gastroschisis. Well, now I have collected some questions for Amolia from the chat area, and our moderator, Dr. Muhammad Abdulaziz, will prepare questions for the other two speakers. So, Amolia, are you ready?
Yes, sure. Please go on.
Okay. From Ali Shalabi, he is asking about the explanation of intrauterine fetal death in gastroschisis, where supposedly there are no other associated anomalies. I would ask the speakers to keep their answers very short so that we can take all questions, please. Go ahead, Amolia.
So the reason for this is not, as you know, gastroschisis, mainly the problem is with the gut. That cannot be the reason for death. So gastroschisis fetus over the last 10 years, the reports are coming out that these fetus are more prone to intrauterine stress. And this is the reason that the birth is also, for these fetus is being attempted between 34th to 37th week. So it's intrauterine stress is very high in fetus with gastroschisis. That's
very good. Yeah. From Dr. Kumar, he's asking about the role of vacuum suction in treatment.
I think vacuum suction, again, if you do something like that, you have to do constant changes in a baby that is already stressed. So I prefer to do a one-stop shop approach putting a biomaterial. If it's a large defect, close it with a second patch or skin, leave the baby alone. The baby has other stresses instead of you coming and using vacuums again and again and changing them. As you know, vacuums can leak and all the other problems associated with them.
Perfect. From Iman Amroon, she's asking about how to manage the bowel edema in some cases of gastroschisis, and what is your technique for umbilicoplasty?
Well, bowel edema, you cannot do too much about it. You'll just have to wait. And when you have mottled gut, just wait. And sometimes you can miss an atresia in these bowel edemas because you never tried to separate it. So just leave it as it is. After a week or something, it will settle down and you can go in. Umbilicoplasty is very, very tricky. There are over 100 techniques if you see the literature. So there are some techniques which I've developed over a period of time, how to flap the skin so that it creates a belly button, because you have to realize if you do an umbilicoplasty in a 4-year-old, by the time this boy or girl is 10, it becomes flat and it disappears. So that's why the techniques are very, very difficult to follow. And I think this is a very valid question. But I have a technique in which I curl it like a snail, and it comes out pretty okay, because when I was working in Germany and Austria, we followed these children up to the age of 16. So I was able to see the results of these techniques.
Perfect. From Dr. Sharif Shhata is asking about the gut adaptation time in gastroschisis, and what are the criteria when you start oral feeding?
Gut adaptation is basically dependent on how much insult the gut has taken. So you cannot determine a time because it's very difficult to predict what is happening. So more important, gut adaptation, fantastic if it's a perinatal event. Prenatal event, you're going to have a problem with that. And the second question was?
Here, criteria to start oral feeding.
You just have to wait and try. So just put NGs on free aspirates, see that the NG aspirates go down, you try again, 2 days the baby will tolerate, 3 days it will not tolerate, you'll have green coming up. So it's just a hit and try method of going ahead with that.
On the mean, how long does it take?
Well, in mean, on most of we did very big studies, which I published in 1999 and 2000 on gastroschisis. So mean is around 67 days. But this is including the complex cases and the simple cases. So that was 60 to 67 days.
Very good. From Ahmed Yassin, he's asking about the role of exit procedure for gastroschisis.
What do you mean by exact procedure?
Exit means...
right, exit procedure.
Yeah.
I don't think there are too many exit procedures that I know about in gastroschisis. Most of the centers who prefer cesarean section or attempted vaginal, they prefer it around the 36th, 37th week, in which these attempts are done when the entire team is there to take care of the babies also.
Very good. From Mahmoud Marai is asking about a difficult situation where you have a cantrell pentalogy, whereas there is cardiac, diaphragmatic, and abdominal wall defect. What is the sequence of events? Which one you repair first?
Well, I think the biggest problem in cantrell is the cardiac. And that's why these babies are, as far as Omphaloceles is concerned, in these babies, as for most that I know, people paint or use topical applications. So Omphaloceles is the last problem. The diaphragm problem, it depends on the extent of that. I've seen complete diaphragmatic agenesis. So in one child, which I thought that it was a diaphragm, when I opened it, it was a pericardium that opened. So the pericardium sat like a saddle on the top over there. So cardiac anomalies, number one, depending on how much hypoplasia if you have in the lungs over there. And Omphaloceles is the last thing. You just paint it and wait for the child to survive.
So coming to painting, here is Sam Sina is asking what you are painting, what you are using for painting.
There are a lot of things in the literature, but a lot of things have gone out of fashion also. Mercurochrome was used in the past. It's not being used anymore because of the toxicity. There is painting with betadine also, but you have to be very careful because of the iodine toxicity. People use even talc. So there are a lot of different approaches, but there is no systematic publications or a systematic review on what is the best approach. There are individual series which are observational studies, but nothing to compare all these observational studies.
How about silver sulfadiazine?
Yes, it has also been used, and people also use that very well. So I don't think there is a problem in using something which is non-toxic. Mercurochrome, definitely not. Betadine, I'm a little bit careful because it can very much increase the entire iodine level in the body. So just be careful at other compounds. Definitely, you can go for it.
All right. This time, this question comes from me. You know, the Abello technique, our friend from Latin America has published very good results on the use of Abello technique. Do you have experience with that?
No, I do not have any experience with the Abello technique. Yeah, sorry about that.
No problem. They claim very good results within 1 week, 10 days of applying this patch, and they have actually a good series about that.
Well, Sami, it always depends on the size, what you're treating, and the complexity also. So, and you know, if you have a child who's not tolerating feeds, the child will be in a complete catabolic state. Even the patch integration is a problem. You need a child which is in a proper anabolic state to have the patch integration.
Yeah, no, that's right. Now, this comes to the end of questions for Dr. Amolia. I would like to thank you again for a very nice coverage of the subject and answering this question. Now I move the questions to my friend Dr. Muhammad Abdulaziz to ask the other two speakers. Dr. Abdulaziz, you are ready?
Well, Dr. Sameh, we are not ready with the rest of the questions, and
Dr. Abdulaziz is not ready?
yes, he's not ready.
Okay, I have collected some questions for Dr. Osama, and again, I will ask that the answers will be very short so that we'll be able to cover all the questions. Dr. Osama, are you ready?
Yes, yes, please.
There are questions about laparoscopy for orchiopexy in Prune belly syndrome. How about the pneumoperitoneum? How about the port stabilization?
Yes, as I pointed, the degree of laxity of the anterior abdominal wall in cases of Prune belly syndromes is not the same. So if you have the extreme of the spectrum, it may not be possible, it may not be an easy job, even if you want to do just cutting or transecting the testicular vessels as a first stage. Fowler-Stevens, it may not be very easy jobs to go and do the procedures in a laparoscopic way, but and in these situations, I prefer to go and do it open. And sometimes, as well, you may add some other surgeries like abdominoplasty for these cases, especially at the age of 1 year. If it is possible to have laxity and flaccidity of the anterior abdominal wall, that can will allow you to use the laparoscopic techniques. So it is very important that you have to go to the abdomen through an open technique, and you have as well to fix the ports, the scope, the instruments by suturing. And as Dr. Saxena said in his papers, you have to use a longer instruments rather than a shorter one. And as you see, as well, it's very important to place your ports in an area where the laxity of the abdomen will not be so much. And as you know, in cases of Prune belly syndrome, the flaccidity of the anterior abdominal wall increase as you go down. And actually, this will be very difficult sometimes because this is the site where the port for laparoscopic orchidopexy supposedly to be. And so you have to go up somewhat higher in positions to place your ports for effecting laparoscopic managements of these cases.
Thank you so much.
As well, very important things is that before you embark on doing transections of your testicular vessels, you have to examine the vascular arcades to make sure that there is a good collateral with the paradifferential vessels, which will be the source of blood for these testes when you cut the testicular vessels, as well as you have to adopt the gubernacular sparing approach where you have to keep the gubernacular vessels and the gubernaculum not affected or not touched. So these are the three sources of blood vessels to the testis. So at least you have to keep two of them, the paradifferential, and make sure that there is a good collateral and communications or vascular arcades between the two systems to avoid the bad result that can occur in these patients, especially if you do them on 2 stages. If you can do them with vascular sparing, I mean, without cutting the vessels, this will be a very elegant one, but actually this will be a very lengthy operations, and I didn't try to do it, especially in cases of prone belly syndromes, because I found that it is difficult to do a full mobilization without transecting of the vessels all in one shot.
Thank you very much. To answer one comment from the chat area about the Abello technique, of course, I meant Abello technique in Omphaloceles, not gastroschisis, because it depends on an intact amnion. And our colleague, Dr. Ahmed Khairi, Chief of Pediatric Surgery at Alexandria, actually has got a good series and very good results with Abello technique for Omphaloceles. Now we'll be back for Dr. Osama Al-Naggar. Would you consider that circumcision should be a routine in treatment of prone belly syndrome?
Yes, yes. Circumcision should be a routine in prone belly syndromes. It can help you to decrease the possibility or incidence of urinary tract infection. It is one important step that you have to do to decrease UTIs in these patients, which is a survival determinant for patients with prone belly syndrome. The recurrent urinary tract infection is very important.
At what age? At what age, Dr. Osama?
Circumcision, you have to do circumcision as soon as possible. So you can do circumcisions in the neonatal period, as we are doing here in our country. All the patients can have circumcisions very early, and I think this is one of the important situations where I can advocate doing neonatal circumcision. This is not my own policy in circumcisions. Usually I do circumcision later on, at least at 3 months of age. But in cases of prone belly syndrome, especially if you don't have a megalo-ureter, so you can do circumcisions, and it should be very early.
Very good. From Dr. Hisham Shtouri, what is outline for management of mega-ureter? Dr. Osama.
Yes, as I said, it depends on your philosophy or school of thinking that you are adopting. So if you are going to do a comprehensive total reconstruction, so you are going to deal with the dilated ureters, and as I explained in the prone belly syndrome, you have to differentiate between the upper ureter and lower ureter. And actually, the bad ureter or the very defective ureter in the prone belly is a distal ureter. So what are you going to do is to do either resection of these distal ureters, a reimplantation of the upper ureter, but as I said, that resection of the distal ureters may jeopardize may jeopardize the weaved blood supply to the ureters, and so this may be associated with a higher degree of obstructions. In cases of, if you don't have a prone belly syndrome patients in a good shape, he is having a labile renal functions. He had a stasis, and he had a sort of deteriorating renal functions. So divergence by doing bilateral ureterostomies is a good option. And also you have to place your ureterostomies in the distal ureter as well, because if this patient made it, and if this patient improved, and you want to do a reconstructions or underversion of this patient, so you are going to resect these distal ureters where the ureterostomy is there, and then you can do reimplantations of the upper ureter. So ureterostomy, either unilateral or bilaterals, depend on the situations, could be another options for managing these dilated ureters. Or you may manage these dilated ureters by just giving antibiotic prophylaxis, because the reflux in these cases will not improve, and as well it works as a pop-up mechanisms, as a lowering of for the pressures in the blood, and this is a blessing for the upper tracts. If you have a lower pressure, lower tracts without repeated urinary tract infections, so these patients were not going to deteriorate, and so you will achieve your goal of managing management by preventing recurrent urinary tract infections by giving a long-term antibiotic prophylaxis for these patients.
Thank you so much. There's a question again from the chat area about, that comes for me this time. In Prune belly syndrome with bilateral intra-abdominal testis, could we use the Shihata technique for bringing down the testis without dividing testicular vessels? As Professor Osama mentioned, will be injurious to divide the main testicular blood supply. Of course, it is a good option, but in my experience, I had come across 3 cases of Prune belly syndrome with intra-abdominal testis bilateral, and all of the cases were abnormally high, almost subrenal testis. I don't know if this is a feature of Prune belly or not. In this particular group of patients with a very high intra-abdominal testis, you cannot perform Shihata technique with bringing the testis to the contralateral side. So I exceptionally did Fowler Stephen in these cases. And they,
Can I add on
yes.
this, Dr. Sad?
Yes, please go ahead.
As you said, that actually the site for the undescended testis in cases of Prune belly syndrome is in the folds of the ureters at the entrance of the pelvis. And if I understand the Shihata technique, you are hearing me, Dr. Sad?
Yes, yes, right, perfect.
Yeah, if I understand the Shihata technique, actually, you depend on the Valsalva maneuver or the Valsalva functions of the abdomen for due tractions. Am I right or not? I mean,
well,
that's the increase in the intra-abdominal pressures will move the intestine or the things inside, and this will be the stretching force, right or wrong?
At one time, we had this feeling, Dr. Osama, but the majority of the effect is coming from the weight of the small bowel on the stretched vessel. So yeah. I know your implication, but the weight works better.
Yeah, but this is what I mean, but because actually you may not be able to have enough weight in case of Prune belly syndromes because of the outwarding position of the intestines for these patients, and as well you will not have an adequate pressure. So for my minds, doing Shihata technique may not be applicable in cases of Prune belly syndrome because of these factors, because you need something to stretch your cord, and the factor that I understand from your techniques, the weight of the intestine here, the weight will not be directed
so effective.
To maybe, but I think that
I agree.
For me, the best way to deal with with undescended testis in Prune belly syndromes is do them at 1 year of age, an open technique, associate them with abdominoplasty.
Very good. Maybe even earlier, because among the reports that you're doing the technique earlier, maybe at 6 months, leads to much higher success rate.
But the problem of earlier, this is the change in paradigm about thinking about Prune belly syndromes. Doing it very early, it's very aggressive and very lengthy operation that may not be suitable for every patient. As well as I told you, in the first year of life, actually a lot of the bad Prune belly syndromes will be naturally selected. And so you will not do these aggressive operations in very young patients who will not survive the time. So doing the surgery for Prune belly syndromes correction, of course, if you have to interfere early by vasectomy, ureterostomies, or any sort of divergence because of obstructions due to atresia of the urethra or hypoplasia of the urethra. But doing the surgery at 1 year of age, I think it is a good thing, because you are going to guarantee a good outcome, because you are dealing with the best possible group of patients with Prune belly syndromes. If you generalize or say that I do it very early, you may do these types of surgeries, which is a very extensive and very lengthy and very dangerous one, carry a lot of morbidity, and this may not be even of any value for patients who will not survive because of other factors like renal dysplasia or all these things. So maybe my message is 1 year is an important point of time that can be of value in dealing with our patients with Prune belly syndrome.
I agree. That's a good suggestion. What do you think, Amolia? 1 year is good to go for on the synthesis in prune belly?
And that's why we have these problems with the laparoscopy. And regarding the laxity of the abdomen, it would be difficult to use your technique because you need counter traction for the testicle, which I think will be missing in this case. That's a unique part of the prune belly.
Yeah. Yeah, I can skip prune belly cases for my cases. No hard feelings. No problem. Well, I go now for Ali Shalabi. Please unmute yourself. Actually, very nice presentation about analysis of the mortality. Why do you think there is such alarming difference of mortality between our part of the world and the normal incidence of survival over 90%? I need to know the secret. What is the major pitfall? Where is the problem?
Yes, we're trying to answer that question ourselves. When we looked at all of the risk factors, it starts from the antenatal detection. And the antenatal scans in Egypt are not done on a regular basis, and the frequency of antenatal scans drops dramatically after every subsequent pregnancy. Pregnant females tend to be quite regular on their first pregnancy, and then any subsequent one, they drop the frequency. And if the first scan is normal, they tend to disregard it. So these cases are not detected. They're often then delivered in remote centers that do not have any experience resuscitating them. And then there is the lack of knowledge about resuscitating. So the children then are arriving at the centers severely dehydrated and severely septic. And then there is also perhaps the medical knowledge in some of the centers that traditionally would rush these children to theater, thinking that immediate closure was the solution, where actually very judicious resuscitation with fluids and antibiotics and following with arterial blood gases, etc., would be the key to survival. And of course, sepsis. It's a huge issue across the board. All of our cases are suffering from this. There's a huge issue with antibiotic stewardship and strict antibiotic protocols. The antibiograms that come out or the culture and sensitivity reports that we see are really horror stories of the antibiotic world, because you would find that the organisms are resistant to almost every single antibiotic known to man. And so it's a huge challenge to overcome sepsis, to overcome very entrenched, very established attitudes to infection control and to the use of antibiotics. And I think the combination of all of these factors is what leads to this terrible mortality.
Thank you so much, Ali. There is a question from Ahmed Yassin asking, do you have TPN in your center?
Yes, we do. We do. And we're lucky that it used to be a few years back quite a rare event, but now we have regular supplies of TPN that are actually tailored to the children. We have actually resident in-house clinical pharmacists that really support our efforts, and they have been really instrumental in changing how we manage the cases. But obviously, and we insert central lines on a regular basis as well. It's part of the protocol, especially for esophageal atresia and for gastroschisis. But still, we have issues with sepsis and central line associated infections.
Thank you so much. I think this brings us to the end of our webinar at exactly 2 hours of webinar time, which is very quite reasonable time, where after that you start to get drop out of the audience, the maximum tolerance of the very rich, nutritious dose of information. I would like to thank very much our distinguished speakers. Amolia, Osama, Ali, for a very enriching dose actually of updated information about a previously unpopular subject, but you made it popular and now a lot of people interested. The audience have been wonderful in shooting very experienced questions. I enjoyed reading them. I hope I didn't miss any of them. And I will pass the microphone to my co-chair to give the closing statement. Sharif.
Thank you very much, Sam. I think that you said most of the things that I intended to say about this. Thank you for the presenters for highlighting this out-of-fashion topic, and I think most of the attendants will they would be encouraged to update the knowledge about dealing with the abdominal wall defects and the management of the urological and GIT conditions. I would just one comment from me about your excellent question about the secret of why are we having very large number of mortalities. I think we see the presentation of Dr. Amolia. Again, he would answer this would be answered in this topic about the fetal diagnosis and about the termination of pregnancy in early weeks of pregnancy, started from the 35th or 36th or 37th. This was a really excellent presentation, and this is to reduce the mortality. I think this would get us to a more preventive ways of having complications with the disease rather than managing the disease itself. Thank you very much.
Thank you very much for a wonderful webinar and evening. Hope to see you next week in another webinar, and thank you again for all speakers.
Thank you so much. Okay.
Thank you so much.
Thank you.
Thank you so much. Bye-bye.